I guess one question that I sort of have is in regards to these third generation EGFR inhibitors, when do you think they're available and how effective do you see them being in people, particularly with the T790M?
So certainly based on these small phase 1 trials, I'm very encouraged. We saw sort of consistent improvements with all of these drugs. These are phase 1 trials, and it's likely that it will take more patients to get there, but my hope is that with current judgments on clinical trials based on small numbers with rapid improvements that we would see drugs in this space within the next couple of years. What's interesting about this, though, is so certainly they're effective in T790, but that may become the question. If they're effective in T790, would they be effective even earlier? So will these third generation drugs go into the frontline setting? Remains to be seen.
Yeah, and you kind of alluded to it, but maybe if you just want to expand. For people with EGFR mutations who have c-Met amplification as their mechanism of resistance, is there data in regards to crizotinib in that particular group of patients?
So there have been studies looking at patients on crizotinib, and there have been studies looking at changes in the driver mutation. So if the EGFR or if c-Met has been amplified, and there have been some case studies showing some responses. More frequently, there have been some MET antibody studies. Unfortunately, I think that's an area that requires a fair bit of work still. The absolute number of patients remains small, and so it's challenging.
Yeah, so do you foresee at some point in the near future then, based on these drugs in those contexts, that we will be rebiopsying patients, sort of not for on protocol purposes, but just for purposes of just standard of care, just rebiopsy of people as they maybe develop resistance to different drugs?
Absolutely, and again, so we tend to rebiopsy now for our patients if they develop acquired resistance, to find out if anything has changed. But as we get better drugs and as we get second and third and fourth generation drugs that may be effective and have a better understanding of the growth signals, I think it will be a standard of care. What's more exciting, I think, is if we actually get to the world where we can look at circulating tumor cells and detect these aberrations. We may be able to detect early resistance at a time where radiographic resistance has not yet occurred.
Yeah, that's sort of an interesting topic for me. I know that it kind of seems to have gotten more traction in the world of breast and prostate cancer as can be predictive of outcomes. I'm just, how far developed do you think this concept of circulating tumor cells is in the context of lung cancer? And maybe just you could get all the information you need from a blood test, and then you wouldn't need guys like me anymore.
You would be doing the blood testing.
Okay.
So it's certainly it's difficult. Talk about a needle in a haystack, right? I mean, this is if we're really looking at microscopic burden of disease, finding that single cell is difficult. My hope, though, is that we'll get a little bit better. That sticky plate will actually hold the tumor cells, and we'll be able to look. Often patients will come into clinic and ask me, when is it ready for prime time? I think it's a little bit farther off than getting next generation sequencing as standard of care for all patients.
Yeah, definitely. There's a question from one of the viewers in regards to first-line therapy in an EGFR mutated patient. Selection between afatinib versus alatinib, how do you decide which one of those you want to use? What are the considerations that you sort of take into account?
That's a great question, and it's one that I have changed over some time. So I have to say that as I've gotten more comfortable with afatinib, I think the toxicity is manageable, and I think that was one of the concerns many of us had, that afatinib, for relatively similar results, caused more mucositis and more diarrhea. As my experience has changed, I feel like they're roughly equivalent. Certainly, there's interesting overall survival results from LUX-3 and LUX-6 that were presented at ASCO this year, and the afatinib survival does seem to be promising as compared to the historic erlotinib survival. These drugs have not been compared, and I don't know when they will. But I am using a little bit more afatinib than erlotinib this week. But in all likelihood, we don't have enough data to say that one is superior because they are disparate trials.
I see. Another question from one of the viewers. If you have a patient who perhaps is not doing that well that you're seeing in clinic with metastatic disease, and the molecular sort of testing results aren't back yet, and it may be a week or two for whatever reason, what's your thoughts about initiating just chemotherapy on these patients without waiting for the molecular results?
It's a great question, and one that we're faced with not infrequently still. So if a patient has rapidly progressive disease and performance status due to the cancer that is deteriorating because of progressive disease, then I think the appropriate thing is to start chemotherapy before you have the test. I would never wait and let that patient sort of out of the window. If we look at historic data, we know that without treatment, patients live 4 to 6 months. And so if they've undergone a protracted diagnostic workup and we still don't have the answer, I think chemotherapy is absolutely the right thing to do, with the idea that we can switch over to erlotinib or afatinib, or excuse me, not afatinib, just erlotinib as sort of maintenance therapy, or they can be salvaged. I think one other issue that sometimes we deal with clinically is in a patient who is frail and has performance status that's reduced for a lot of other reasons, not only their cancer. And the question is, should the patient only get best supportive care and be referred to erlotinib, or should I try to improve their survival with erlotinib without knowing the mutational status? And I've actually done that, and I think that's appropriate if you discuss toxicities and survival expectations. Certainly, I think we've all been surprised in an elderly patient in whom we don't have all of the data in terms of molecular testing, or they can undergo another biopsy, that will occasionally see a good response. But that would only be in the situation where there was no option to give chemotherapy. So a priori, I'd already made that decision.
I guess the question that I would have would be that then if you initiate chemo on a patient without the molecular testing results, if they do then become available a week or two or a month down the line, would you continue with that, or would you then switch to the targeted agent?
My practice is generally if they're tolerating chemotherapy and having a response, I usually will finish finish 4 cycles of chemotherapy and then put the patients experience toxicity, or if they end up having a less robust response, I may stop earlier.
Another question is what your thoughts might be in patients with more limited disease in regards to use of EGFR inhibitors in the adjuvant setting.
So it's certainly exciting and one of a lot of discussion. So 2 trials, as you likely know, were presented this year at ASCO, the SELECT trial and the RADIANT trial. The SELECT trial was a single-arm study looking at early-stage patients who were EGFR mutant positive, and they were placed on erlotinib. And RADIANT looked at all patients with early-stage disease. In the mutant-positive patients in RADIANT and in SELECT, it appeared that the progression-free survival of these patients was improved in the SELECT trial compared to sort of historic controls, and in the RADIANT trial for the years that the patients were on erlotinib. Certainly begs the question, are you changing the natural history of the disease or just pushing the recurrence out for a longer time? Because in the SELECT trial, patients sort of had a better survival. As soon as you stopped the erlotinib, that progression-free survival started going downhill again. I believe that this is still, that we still need to get more data. We'll have the Alchemist study, our national effort to look at adjuvant trials, and this will be an arm looking at adjuvant erlotinib versus placebo in early stage patients.
Sort of a related question that's been posed is if you have any thoughts on using targeted therapies in the neoadjuvant setting, so maybe to facilitate operability on someone who's otherwise not a surgical candidate.
So in the stage 3 setting, we actually have a trial from the RTOG looking at induction chemotherapy for a short time, for weeks, with one of the either EGFR tyrosine kinase inhibitor, erlotinib, or crizotinib, followed by chemoradiation versus chemoradiation alone. It may be that that's too short and patients need more of the drug, but certainly we're going to see if there's an improvement in radiation delivery and outcome by decreasing the cancer burden up front. I would say that I think anecdotally all of us have treated a bulky stage 3, for example, with erlotinib to get them to radiation, to decrease the radiation fields and the toxicity. But we certainly need data for that. There have been some efforts in proof of principle studies looking at sort of an induction approach with erlotinib in patients with stage 2 disease, and we've seen some nice responses. But again, I would not do that off of a clinical trial.
Okay, so not yet.
Yes, stay tuned.
And then in regards to toxicities from targeted therapies, there's a question about nausea and skin rashes. I'm not sure which drug they're referring to, but any thoughts about management of side effects that may be unique to some of these targeted therapies?
So I think it's difficult. I mean, when patients are getting systemic chemotherapy, we're seeing them every couple of weeks. The patients have a lot of time with our infusion nurses and our clinical nurses. Often with these targeted therapies, we write the prescription, and unless we drag patients in for the toxicity check in 2 or 3 weeks and then an appointment with their next scan, we don't hear about the toxicities, and they can be very, very difficult. So we tend to, we've developed an educational tool for our patients. We get them into an early dermatology referral. We use antibiotics early on, so minocycline, often for the rash, which will help. We try to educate patients on antidiarrheals and encourage sort of that close communication. So we still ask patients to hold symptom diaries so we can see, I think it can be very distressing to patients, certainly. But a collaborative approach with an ophthalmologist, with a dermatologist, good clinical nurses and mid-levels has certainly helped. And dose reductions at work for these patients. So often you'll continue to have superior efficacy by dropping the dose a little bit.
So I guess the question I had maybe was in regards to pemetrexed. I guess the efficacy in adenocarcinomas versus squamous cell carcinoma, is it sort of predicated on the finding of increased thymidylate synthase expression in squamous cell carcinomas? So is there any talk about using thymidylate synthase as sort of a biomarker for pemetrexed as opposed to using histology? It's something I've always kind of wondered about.
I've always wondered about it too. We think that's a mechanism. I guess we don't know. Certainly, I think in some of the larger phase 3 studies, there's likely some data there. But the TS assay, from my understanding, is a tricky one and is a little bit difficult to interpret. So it may be that we're stuck with P63.
Okay. It's fine with me. And I guess I'll ask the last question then, which is, I guess maybe a year or 2 from now, how different do you think the field is going to be in regards to FDA-approved drugs?
My assumption is that we'll see some of these drugs that already have established efficacy broaden their label a little bit. So we are seeing approvals, for example, for ROS1 translocated tumors with crizotinib. I'd be very excited about that. And then some of the drugs that have shown superior efficacy for melanoma, for example, and BRAF mutations as well.
Yeah, it seems like an exciting area. Things just change again, month to month almost.